Hey everybody, it's Jaron and it's Kevin, and we're from RPH Ally talking to you guys about the Pharmacy Rebrand show today. And we've got an exciting episode really dedicated to if we've got all this education out there and we've got all this innovation out there, how do we put the two together so we can actually move the profession forward and get to see these siloed things happen on a scalable stance? So listen to us about those things. Also want to talk a little bit about our support for those that are walking out in Kansas City, Missouri, those kinds of areas and what's happening in the retail space, but really looking forward to you jumping in and giving your thoughts. So we'll talk to you right after this reel. Jaron, you're looking dapper, buddy. I tell you what, that tie looks fantastic. The suit is just on point. Hot date tonight?
Stop it. My hot date was you, man. I wanted to look this nice just for you. And yes. I know you can't see it, but I even got the matching shoes to go with it. So
hot dog. Man,
very important.
Nice, buddy. I love it, man. I think the dressing up for the occasion, I mean, kind of the occasion around all of pharmacy is related to what is happening kind of in the center of the country. And something that you and I have talked about for a bit of just what these folks have been going through and the pressures that are coming up against them, and leads in quite nicely to the rest of our talk. But let's dedicate a little bit of time to your thoughts on what's happening right now with CVS, Walgreens, some of these large major conglomerate chain stores and their pharmacists and pharmacy technicians saying, we're going to have to change some things.
Yeah. I just want to say the first I read of it, I almost started crying, and I'm going to say almost because I'm really manly and I don't want to give the impression that I ever cried over that, but sure. It hit me really hard. And I was so freaking proud to see that we were doing that. We were all unified, getting together and standing up for ourselves, which we historically have not done. Yep. And I just want to say, nobody's going to value us unless we value ourselves, unless we respect ourselves. And it's time for us to unify our efforts and stand up and say, look, this is not right for us to work under these conditions. And we have to stand up for that. So I support you guys. I'm right there with you, and I'll do anything to provide support for you guys. And I'm sure it's really difficult for them right now. And I totally respect that. And I can't express enough how awesome I think it is.
Yeah, it's amazing. I mean, just incredible to take that kind of stress and strain and put it on your back and say that I'm going to be the one that's going to carry some of this load for our profession and step out and do something like that is really commendable. And I hope that we arrive upon some solutions that really work across all sets, and I'm not just talking from the perspective of just those individuals that walked out, but also from these large chain folks that are employing a majority of our profession. I hope things get figured out there as well, for incentives to be in line, for patients to be prioritized, for the health of our profession and all the folks that we care about to be prioritized, so that we can move forward and deliver some better care. And interestingly, I think that segues nicely, Jaron, to what you and I are talking about, delivering better care. We're seeing a lot of models that are out there. They're just kind of in silos on folks delivering better care and moving pharmacy from the state of disarray that is in today, and maybe prioritization that is off from what you and I would love to see it. And many of you out there listening to us, thank you so much for being on. Comment, jump in whenever you guys want to. Where do you think we have to start, Jaron? I know we kind of have 4 topics we want to go over here on how to, innovate and how to change pharmacy education so it's actually meaningful. But lead us along the way, buddy. Where do you want to start here?
So, as far as, just when you think of the morph that our industry or our profession is kind of going through, it's been talked about for a very long time. And you can tell that exponential curve that is the change of the pharmacy profession. We are right on that area where it's starting to change a little bit more dramatically, a little more quickly. And so it's really important for us to start getting the word out of these opportunities and to start educating each other, not only each other about the opportunities available and what our possibilities are, but we also need to educate our healthcare colleagues of what we're capable of doing, because we've historically just kind of, honestly, I think We've spent a long time in our profession allowing everybody else to relegate to us what our profession does and how we're useful. And because they don't know what we're good at, that has not been beneficial for us. And in turn, our contribution to the team has not been as beneficial as it could be. So we need to get the word out. We need to start educating. And there's several aspects we need to do to get the education out there. I think there's a few problems to education. First of all, like I said earlier, nobody's going to value us unless we value ourselves. And so we have to start having professional organization support. We need professional organizations to start helping and providing infrastructure and support and education to get more pharmacists aware of how to do this and give them the support they need to start implementing it.
Yep.
We pay dues to these organizations. We need them to start taking on this mantle, doing more proactive work, more advocacy. And right now, this is just an area of pharmacy that no professional organization has really truly understood yet. There's a lot of individuals out there doing it on their own. Jamie Wilkes and Blair Telemeyers and Amina Abubakars and Jenna Quinn's. There's a lot of them out there doing stuff independently and making waves without any professional support. And there's just not enough pharmacists are going to be able to do this. So first of all, we need to get that support, more education. And that being said, understanding how to provide services and bill for services is a massive undertaking, especially as a pharmacist. And so we need to start providing that education, that support to our profession and to each other so that we can start growing these services. And that being said, once we get enough of these, firms growing, we'll be able to educate a lot more pharmacists a lot more quickly. And that exponential curve of education, I think, will really take off from there. That's kind of where I'm starting off, is just within the profession. What are your thoughts on that?
Yeah, I mean, I think just in the profession, we have to recognize that that is a step that is necessary for us to take moving forward and get some collective buy-in behind it, right? We have to be able to have an organized approach to it. And without that organized approach and emphasis, we really start to bifurcate, trifurcate, just individualize. Each individual is going along their own paths. They're creating their own next steps. They're having their own separate meetings. They're trying to break down the exact same silos that the previous individuals broke down. And that's unnecessary. So I think to really be able to scale this kind of model, that kind of collective approach toward understanding what is this model, how does it change what the status quo was or the current operational and or vocational settings are, and how do we actually employ individuals into these new settings? So I think that's a great place to start, Jaron. It's where we kind of have to start. I know that most of us, though, we started it inside of our didactic training, right? And so I think that's the one that you and I want to jump into probably next is, how do we change the way that we're currently, educating, or changing the way we're educating the graduates that are coming out of university settings that and it's no fault to anyone inside of university settings, but may have faculty members that have not experienced these kinds of unique pharmacy practice settings, especially these kinds of pharmacy practice settings that are paid for profit, not paid for through grants and or university funding. Any additional thoughts there, Jaron, on how we can expand upon that, educating those folks that are inside of that setting?
Absolutely. Education is kind of the bottleneck of what prevents us from expanding our professional services right now. And if we can not only, if we can start educating our students in pharmacy school right now, that's going to expand and widen that bottleneck. So it's not a bottleneck anymore. Instead, we have a massive growing workforce capable and understanding how these services can be done, where to find these jobs, how to build these jobs, how to collaborate, how to document, how to bill for your time. Because even though we are not providers yet, we have tons of opportunities out there that are just as good as being a provider that bills for their time. And we have to utilize these opportunities anytime we get the chance. And I think right now there's not a lot of infrastructure in the institutions that teach pharmacy students, but I think the people like myself and Jenna and we need to start reaching out to these organizations and offering these opportunities as electives and say, hey, here's something I can offer your institution so that we can start educating our pharmacy students. Start on the elective level for now and just expand on that as we get more interest and more awareness, basically. What was the other part of your question? I don't remember. Was there another aspect to that?
No, that was really it, Jaron. Just, I mean, really looking at like what is the current didactic model? What is currently being pushed upon all these universities when it comes to standards, that they have to uphold in general? I think that conversation has to happen. Like we have to find a way to say that standard practice and or standard education has to be reformatted so that instead of having folks come in that are quote unquote unique opportunities in pharmacy, this is part of the core curriculum. Like this is the future workforce of what pharmacy is needing to be and become to avoid a lot of the issues that we've got ourselves pigeonholed into when it came to product understanding and management. Now
Right.
those things are starting to go away. And so I think there's one element. The other one is what you just touched on when it comes to offering elective courses or broadening kind of the overall networks of all these universities to go, hey, who are the thought leaders out there that can really connect the dots for our universities and for our students and be able to connect dots there? I was just messaging with Dr. Sue, and I know she's doing a mentor program and trying to have more folks mentor young students and other professionals on what they're currently doing. The other piece I feel like, Jaron, is just necessary. We talked about before is the secret sauce. Like instead of having those silos, making it easier for the academics to be able to get access to the processes that are happening inside of these individual unique situations. So what did they do to be able to create kind of the elements they have? But I'll play devil's advocate for this next question, Jaron.
Well, first of all, I'm glad you specified didactic because I ran into somebody at a conference, and unfortunately I've been to 3 conferences in 5 days, so I don't remember who this was or what conference it was. But I ran into somebody who said they were talking about one of our innovative colleagues in a state, I think it was in Colorado, might have been Nevada or New Mexico, but they said the pharmacy schools could not send students to them on rotation because they didn't have a specific pharmacy site that they were linked to. And so once again, the education, we have to update our antiquated institutional models to reflect innovative practices so that more students have more access to these innovative models. So thank you for pointing that. It just sparked my mind. So continue with the question.
No, beautiful. I think that's really well said. I think before we get into what I'd segue with that piece, because I mean, really, I'm thinking, who Jaron pharmacists need to be able to connect with? It's not other pharmacists, right? Who are going to open the doors for us, right? Is really how we'll segue. The next piece that I would argue with, if I am a current student or if I am in academia and training students for the workforce, it's how can I train individuals to go into work in places that there are no current positions available, right? If what I'm trying to train them for is entrepreneurship and build it on your own sweat equity, that is not an attractive, just greasing the skids for opportunity immediately upon exit, right? So give me some thoughts there, Jaron, on how we can start to change that other side, because they're not wrong on all parts there. It is an uphill battle for a lot of individuals that are starting in, and there is an educational curve that we think we have to correct. But give me some ideas there on how we actually make those opportunities more accessible.
So, there's a lot, and, obviously our key component here is education and infrastructure. And right now, the infrastructure in place doesn't recognize what we're capable of doing. We have healthcare colleagues who really don't value or see what we're capable of doing, and that's part of the obstacle we have in place. And when they recognize what our value is, that's where we really take off on that trajectory. I think one of the biggest obstacles that I have is, ironically, early in my career, this never happened. This is something that started to happen a little more frequently lately, where people just don't understand the point of a collaborative practice agreement, how this is a team-based effort. It's a communicative and collaborative effort. We all get on the same page. We communicate frequently. We engage in discussions to make good decisions. There's just been a few times lately where they don't understand how, and the funny thing is, I provide a lot of context when I make a decision in my reports.
Sure.
It's all there. And I do that because I don't want people to wonder, how did Jaron come to this conclusion? I want them to read through that whole thing, and literally my entire thought process is followed throughout the entire paragraph. Here's the problem. Here's the patient's history. Here's their medication use. Here's the interactions. Here's their kidney function. Here's their allergy. Oh, I already said allergies. But here's how I got to this solution right here.
Yep.
And lately, there are some providers who were questioning if it was appropriate, even though I had everything spelled out as to why it was appropriate. Right now, and one of the biggest problems we have is in nursing homes specifically, they're quite used to pharmacists not doing anything more than what they have to do. Yep. And so when a pharmacist shows up and says, hey, here's a bunch of stuff I found, and under a collaborative practice, here's what we can do, and it's all ready to go, and you can fix it right now. They kind of get scared by that. And it's happened quite a bit lately as well, where they question the judgment or the decision-making, even though it's all part of the product. It's all been discussed. It's all been part of a protocol. It's all according to current evidence and literature and according to the patient's history. And so we need to educate so education not only applies to us as a profession showing our value and what we bring to the table in the healthcare team, but also educating how can I explain it? I think I lost my train of thought. But ultimately, the nursing homes and our professional health colleagues need to understand what we're bringing to the table ultimately.
There's a strange comfort level with the pharmacy technician gets me access to the drugs, and that's it, right?
Right.
That's kind of the status quo. That's what you talk to the nursing staff, and they're trying to, inside of a hospital or inside of some nursing homes, they're really saying, you're the ones that bring me the bubble packs. Like, that's what I think of you. And then I put them in the cart and I do everything else. You're the ones that you go through the charts for some reason. Then my doc says, we're going to make some changes. Inside of the hospital, you're the one that takes my doctor's orders and then looks at those and then just gets me access so I can get those drugs out that the doctor's already ordered. You just need to do your job so they come out of this magical machine.
Right.
Well, that's been the perspective, right? In general, until someone shakes the what out of it, Jaron.
Yes.
And goes, no, that's not our job. Like, that's what the result of our job is, right?
Yeah.
What our job is to make sure that you don't kill someone.
Mm-hmm.
What our job is to make sure that our patients collectively get the best results possible from treatments that are offered. And I think once that mind shift goes on of, a physician going, you've saved my rear end several times, and I trust your judgment and your expertise, they will never, ever want to practice without a pharmacist with them, right? I mean, that's evidence. The AMA has come out with information on physicians saying that exact same statement. I would never practice without a pharmacist again. Like, they're integral to the collaborative care team. I think the next things that we have to get past, though, Jaron, is I was just commenting on LinkedIn. We had a direct primary care physician talk about, hey, great, direct primary care, future of healthcare, kind of thought process. For those out there that don't know about direct primary care, really looking at a subscription model, which in pharmacy, we're seeing that come up too. But instead of going through insurance, et cetera, it's really a direct cash payment subscription model. So you have a relationship with your primary care provider. They cut out a ton of overhead and additional middleman bloat and they can directly take care of their patients, usually to a greater degree, more time with their individual patients, more visits per year, and hopefully, greater health outcomes. But my comment inside of there, Jaron, was really this. They were looking at saying direct primary care is essential. We need to only have panels of patients that are somewhere around 500 patients total. And this is why we really need to leverage our physician assistant and our nurse practitioner colleagues, inside of the space, which I don't disagree with at all. But the one thing that the evidence shows is if you want to do chronic care management really, really well, you know who you call? It's pharmacy. Like that.
Right.
We do it better than anybody does. And so getting the thought process and getting interwoven systems to go, this is how you bake the cake. This is how you write the recipe. This is how you do the cookbook. You add these pieces together, and one of those pieces is pharmacy. The more often we see that over and over and over again, that John's practice has a pharmacist, and Sue's practice has a pharmacist, and Bill's practice has a pharmacist, we'll just start seeing that reciprocity over and over and over again, that it gets included, unless we can find ways to include that inside of legislation, which is something I saw this morning that I wanted to ask you about, Jaron. Is one individual commented and said, we need to make sure that legislation that is written says provided by a pharmacist instead of leaving it open to interpretation. I can't agree with them more, Jaron, but I know it's an uphill battle, and you've gotten legal help to be able to help us with some of those uphill battles. Your thoughts on that part of the equation? Because I think everybody else out there agrees we need to educate our colleagues on what we're good at and then showcase it as much as possible, make it part of the inner workings in our fabric. But that requirement, that little legal statement to be able to plug pharmacists in for the best part of the patient, I want to hear your thoughts on, bud.
Yes. We need more verbiage in regulations and laws that specifically state what we bring to the table, and relegate or bring us on the team to perform specific tasks that are not tied specifically to a product, but more our expertise. And, when thinking about that specific, so when you're talking about the regulations and verbiage, I think another item that I would add on top of that is, I don't remember if I've brought this up on this show before, but right now the CMS skilled nursing regulations specifically state who can write an order. Okay. So obviously MD, NP, PA, then it states who the MD can delegate to writing orders. And obviously it says within state law, but also the physician can delegate to a dietitian regarding diet to write orders, or to a therapist regarding therapy, writing orders on that behalf. If we were to add a specific line item, they can also delegate orders about medication management to a consultant pharmacist under a collaborative practice agreement. And that's free from conflict of interest or something like that, to make sure that we're not over-prescribing, that we keep the key component of de-prescribing in the heart of it all. And if we had that line item in there specifically stating that pharmacists can do this, it would do a lot to open up that educational aspect and get more facilities on board. Oh, well, this will simplify the process if we start hiring pharmacists that are capable of going under a collaborative practice with our medical group and start writing more orders and fixing more problems, as opposed to just showing up and talking about where bleeding risk is with aspirin and Plavix, or to rinse your mouth with Advair, all the stuff that nursing staff already knows. Once we add value and stop doing all the archaic processes, that makes a difference. And if we have those regulations, it opens up more opportunities in that verbiage. So I hope I answered your question.
Perfect. Yeah, and it leads us into I think the next topic is really this. When it comes to the world that I live in most, Jaron, is digital health. And so inside of the digital health world, there are oftentimes risks that a company has to take to be able to enter into a contract agreement with an individual payer. And those risks are usually related to some level of capitation and some level of metric measurement, like how much are you moving the stick? And so I think that is something that is really fascinating for us, Jaron. I'd love to hear your thoughts more on how can we start moving that needle. We talked about how do we move the collective needle of professionals in the profession, professional organizations, academia and students, and our colleagues. But the other piece is really the legislation we touched on a little bit. And the last one I'd love to jump into is, how do we change payers' minds so that they start recognizing we need to start leveraging more pharmacists? And what's your experience been there?
I think, to answer your first question, we have to fight uphill battles.
Yeah.
Like, those uphill battles are there right now. But if we fight those uphill battles, the resistance will get lighter once we prove our point. And it's proven time and time again, like you said. Once there are tons of physicians who are now coming out and publicly saying, I never want to work without a pharmacist ever again. Yep. Because pharmacists close to those MDs fought uphill battles to make that happen and make them aware. There is a lot of resistance from a lot of different angles, not only within our profession, but outside of our profession and in healthcare in general. We have to fight uphill battles. And like I said last week in closing, we have to have pharmacists with a healthy disregard for the impossible, because we have to fight those battles. And what was the second part? To move the stick, that was the first part. What was the second question?
The second question was really along the lines of taking that exact same thought process of fighting that uphill battle, and how do we translate that into payer organizations, insurance, employer, etc., looking at pharmacists and saying, we want you part of the team, and this is how we're going to directly reimburse you for your services.
Well, I'm probably not the best one to answer this question, but I know Jenna has done a lot of work in this, and she's a pioneer in this regard. I think what the perspective she took is she gathered a lot of very useful and paid a lot of people to help her gather and collect this data and quantify it and put metrics together and prove values. Something that I wish I had the ability to do. I would have to hire a lot of people, and I didn't have access. I don't have access to that. So she had built an amazing team to build those metrics and prove the value. And now she's walking into payers, showing this to them and knocking their socks off and starting to get some. I haven't talked to her in a couple of weeks about it, but I know she's going to make some headway here. And these are the types of things we have to do. Unfortunately, there's not a ton of pharmacies who want to take on that metric gathering. And this is where pharmacists have to start standing up for ourselves. Like we talked about at the very beginning, we have to take the mantle of our profession and start proving our value and showing payers what we're capable of doing. It's not just looking at a pill and saying yes or no. It is this pill the appropriate pill for this person based on their medical history and et cetera.
Yeah, I completely agree. I think there's an element inside of there that we have to be able to recognize, is that for the most part, and I'll say this for the most part, we do not get educated on the payment system of modern healthcare inside of our educational tract. We don't. And so that has been something throughout my career that I've heavily focused on, if it's one setting or another, to be able to get a good grasp on how does the money move. And I think that is something that pharmacy in general has to get a better grasp on, is who's getting paid, why are they getting paid, how are the metrics coming across, so we can actually make sure that we're putting food on our table. Mm-hmm. And so those elements, being able to put it into place that are unrelated to margin of individual drug, I think are foreign concepts to a lot of individuals out there that are practicing pharmacists. And so being able to gather that data that you mentioned, Jaron, on, what does one intervention decrease the costs, or how does it decrease the cost of X number of healthcare outcomes, right? Or how does decreasing the likelihood of someone going in and using an acute care model, emergency room, for example, how does that decrease the burden onto a payer system? And what are the likely leading factors that are going toward X, Y, and Z happen? Next piece is likely they go into the emergency room. If I can stop X, Y from happening, because I'm a pharmacist with that expertise, I'm able to stop your patient from going to the emergency room, and therefore I just saved you $10,000 for every single occurrence of them going into the emergency room.
Right.
And so those kinds of factors, being able to put those together, I think are excellent. The other pieces are metrics that are already there in value-based care. And so if you're trying to realize where is healthcare going, a lot of these capitated rate systems are really looking at metrics, right? And per patient per month models on saying, this is how much we're paying you to take care of these patients. And here are the factors that we're going to weigh against for you to take care of them. And I think understanding those elements, which I think we could have Amina on here sometime really soon, and the exact same thing with Jenna to talk about the ways that they're kind of differentiating inside those spaces. But those are my 2 cents, I guess, when it comes to the payer orgs.
Yeah. And you know what? It's also a perfect example of what I said. Like, that is a huge undertaking, a massive uphill battle. But those are battles we have to take on right now, unless we want to be slowly dragged down into the deep abyss of irrelevance, So, but these are battles worth fighting, and we have to do it.
Yeah, and I think the one beautiful thing, we started with it, all of you large national organizations based in the capital, we have a ton of data out there from pharmacists that have done these kinds of studies related to cost savings, and being able to accumulate that data and be able to showcase that to all of your constituents and all of pharmacy, so we can leverage it with payers and say, hey, here is the likelihood of me saving X based on these interventions that I'll be able to provide. Beautiful. It's always nice to be able to have a playbook inside of things.
Absolutely.
Well, I love it, Jaron. Well, thanks so much, buddy, for all those innovative thoughts. We will definitely grab some of those folks and hopefully bring them on the show sometime soon. And if you guys have any questions, thank you all for attending, and your thoughtfulness inside of the show is always appreciated. But if you want to be able to jump on with Jaron and I, or you have any other subjects you'd like us to cover, let us know. And we'll talk to you then next week.
Thank you.
All right. Have a good one.